Good afternoon, everyone. Welcome to the final session. We're on the home stretch of the AMCHP conference. It's a great pleasure to be serving now as your president, and I'm in my first 4 hours, so it's been very exciting and overwhelming, but I'm truly honored. And I hope everyone's having an amazing time. These past few days, learning, sharing, networking, and taking some stuff back home to the staff that weren't able to travel, and hopefully you found things to advance your programs and yourself professionally. I'd like to share with you the results of the 2018 Board of Directors election. Our president-elect for 2018-2019 is Kate Wilcox. Our secretary, Susan Colburn, who's serving her second term. Susan. Our treasurer, Karen Downs, serving her first full term. Our family representative, Donna Yadrich, who's serving her second full term. Donna. Our at-large representative, Dr. Alan Meese, who will be serving his first full term. For Region 4, Belinda Pettiford, serving her first full term. Belinda. And for Region 7, Rachel Hutchins, serving her first full term. We're going to be wrapping up this conference with a few more accolades and a memorable closing plenary from a keynote from Dr. Michael Liu, our former associate and administrator of the Maternal Child Health Bureau, and now with the George Washington University Millikan Institute School of Public Health. Before we move on, though, I'd like to take a few moments to recognize outgoing board members, Rodney Farley, and outgoing president, Dr. Michael Warren. So a few words about Rodney. I think that picture sums it up a little. Those of you know Rodney. But Rodney wasn't able to join us during the business meeting this morning, so I'd like to take a moment to thank him for his long-term service to the board of directors as an at-large representative. Come on up, Rodney. Not only has Rodney demonstrated time after time his obvious commitment to families and children and youth with special health care needs, but those of us know him and understand Rodney well and really appreciate his gift of humor and always bringing levity to the board, even during times of stress and difficult conversations. So really, I started on the board with Rodney 6 years ago, and I'm going to miss you terribly, but I know where you are, and we'll be working together some more. So again, oh, and the picture, this is what Rodney likes to do in his free time, walk his pet rooster, so. But here, Rodney, here. Next, please allow me to personally thank Dr. Michael Warren for his commitment to and the leader of this organization for the past year. For those of you who had not had the opportunity to work closely with Michael, you've missed a chance to interact with a brilliant and committed maternal and child health leader. If you do nothing else, consider making it your goal to find a way to work or interact with Michael in some capacity in the future. You will not be sorry, and you'll be better because of it. Michael represents one of those rare persons who combines a personal mission to improve maternal and child health and public health with compassion for those with whom he works and serves. He is both thoughtful and thought-provoking. He's never reluctant to ask the deeper, harder questions or meaning of things, and always willing to lend his knowledge and expertise without ever making you feel insecure in your own knowledge. He has been a consistent leader and co-leader throughout his president-elect and president terms, supporting the AMCHP staff, membership, and other members of the leadership through some of the organization's most challenging times. He's been a stalwart steward for AMCHP, helping to ensure the success of the AMCHP annual conference as it was relocated out of the DC area for the first time ever, and navigating the constantly changing landscape of the federal policy and legislative areas with diplomacy and care, in particularly challenging set of circumstances over the term of his presidency. As the leader of the AMCHP Board of Directors, Michael has demonstrated amazing facilitation skills, always taking special care to hear people out while encouraging the voices of the board members to come forward to weigh in on important discussions. Similarly, with regard to AMCHP staff, Michael is always quick to inquire how staff are doing and to compliment their work and contributions. Under his own invitation, Michael attended an AMCHP staff meeting and made it his objective to share with them his personal experiences as a state MCH leader and how they might complement his vision for AMCHP. Despite being the Assistant Commissioner for Population Health in Tennessee, an incredibly demanding position, Michael always makes you feel as though you are his top priority. He gives you undivided attention and never shows any level of distraction. He makes you feel though your work is the most important thing of the world. Please join me in thanking Michael for his many contributions to AMCHP and for his time and leadership as the AMCHP president.
That is hard to follow. So I was asked to give a few reflections on the year of AMCHP presidency, and I'm going to be really careful with what I say. One, because I tend to be pretty tenderhearted, and so I'm going to try to hold it together. But two, when I was trying to say presidency this morning in the board meeting, my presidency, I said my pregnancy, and there's a big difference between those two. So if you were not at the board meeting, see what you missed? There's a reason to go to that meeting. But I do appreciate the opportunity to reflect, and I've been thinking about our conference theme, Enduring Commitment of MCH to Families and Outcomes. And for me, that enduring commitment is really about our enduring service. And for me, like many of you, service is a calling. There's a quote that I like from the theologian Frederick Buechner, and he says, "The place God calls you to is the place where your deep gladness and the world's deep hunger meet." The place God calls you to is the place where your deep gladness and the world's deep hunger meet. So with this work, clearly there is deep hunger. We have populations that are in great need. But gladness? Where is the gladness? Every day we work with populations that deal with extreme challenges. We face bureaucracies. We deal with political and cultural realities that we can't change. So where is our deep gladness? So I've been reflecting on that and what that means. For me, that gladness is rooted in two places. One is seeing people for whom I have great respect serve others selflessly and wanting to emulate that, to try to be like them when I grow up. The other is realizing that I've often been the beneficiary of others' service, and I want to pay that forward. So I'll share a little bit of my story and reflection on those two points. I grew up in rural eastern North Carolina. I always say in a town of 500, that's actually where we got our mail. We lived about 3 miles outside of town and lived on my great-grandparents' farm. I knew all 4 of my grandparents and 6 of my 8 great-grandparents, which I didn't realize was an oddity until I went off to college. It just was the way it was, and it was fantastic. I was fortunate to have had and continue to have 2 amazing parents, both of whom graduated high school and went straight to work, and both of whom have had the same employer for 30 years. Their trajectory has been very different from mine, and yet their commitment to making sure that I had the exposures and the opportunities has never wavered. But probably most importantly, early on, they showed me the value of hard work and service to others, whether they were caring for shut-ins in the community, whether they were serving on our town council or on various county boards, whether they were going out in the middle of the night to light an elderly neighbor's gas heater. Service was just what they did. And so I grew up thinking that that was normal. And there were other examples that I was exposed to. My childhood pediatrician, I remember when I went off to medical school, 3rd year you do various clerkships and specialties, and I had the opportunity to choose an external rotation for pediatrics. And so I said, I'd like to go back home and work with my pediatrician because he's pretty amazing. And at that point, I was very focused on learning the science, as most of us are at that point in training. And I remember walking into an exam room with him and doing the exam and talking with the family and walking out. And he turned to me in this very stern face, which he could do very easily, and he said, "Michael, you have to be an advocate for these families. No one else is going to be." And that really stuck with me, because at that point I thought pediatricians gave shots and wrote prescriptions, and I wasn't aware of this broader advocacy role, wasn't really exposed to public health prior to that. And so I thought, what does he mean by that? What is my role in the bigger system? And fortunately, I was able to see through the rest of that clerkship and then through a number of clinicians that I was able to work with over the years just what that meant. So both of those examples, my parents, my pediatrician, give me examples of individuals who have shown me an ideal to which I inspire. And so for that first part of gladness, trying to emulate that, that's where that's rooted. It's not that I have some intrinsic value to serve or be a do-gooder. It's just that I have lots of respect for those folks, and I want to try to be like them. But there's that other piece of gladness for me that comes from how I've benefited from the service of others. I was actually talking with someone about this earlier in the week. I grew up participating in 4-H and loved every minute of it, and had the opportunity to work with many volunteer leaders. And for them, their calling was to offer us new experiences and opportunities. They spent their time teaching me lots of things. One of the most important was public speaking, and it's a skill I used every day. I hated public speaking drills as a 4-H'er, but it's turned out to come in pretty handy as a 41-year-old. They also took me on trips, including my first plane flight for a 2-week summer exchange program in Colorado. We had the state exchange. I actually went to Douglas County, Castle Rock, just not far from where our past president, Eileen Forlenza, lives. That was the first time I learned that all tea was not sweet. I grew up in North Carolina. And when you ask for tea, you got sweet tea. And so we landed in Colorado, and I asked for tea, and I thought, what is this? Turns out not all tea is sweet. But I got to see parts of the country I had never seen and got to have some leadership experiences. And so their calling of wanting to engage and enrich youth benefited me. I also think about my first employer. In our little town, there wasn't a lot to do, but we had a pizza restaurant. And the owner of that pizza restaurant felt that part of his calling was to bring in youth and give them responsibility. So he hired me as a pizza cook, and I could have done that. I was okay at that. I was not great, but he could have let me continue to do that. But he apparently saw something, and after 6 months or so, made me a supervisor and gave me gradually increasing responsibilities. Mind you, this is as a 17-year-old. But what he saw was an opportunity to trust youth with his business. And in turn, we put our heart and soul and our creativity and our loyalty into that. So those are just two examples. I could talk all afternoon about the ways that people have done wonderful things to me over the years. And I think sometimes we get in this conversation about handouts and, people taking handouts. I would argue that those are handouts. Maybe you call them hand-ups. But if those people hadn't been at that point in their lives, fulfilling their calling, doing that work with me as the beneficiary, there's no doubt that I would not be doing what I am today. So I go back to that quote, "The place God calls you to is the place where your deep gladness and the world's deep hunger meet." So where is that gladness again? For me, it's in having the opportunity to emulate the work of people that I hold in high esteem. And it's the opportunity to pay back just a little on that which has been given to me. But I also see that gladness in all of you. I saw it in my first AMCHP conference. I'd been to lots of conferences, a lot of continuing medical education and meetings, but AMCHP was the first place I had been where I thought, these feel like my people. What's kept me tethered to this organization and why I've been honored to be a part of the board have been the enduring commitment. And I've thought upon this reflection, it's really that enduring commitment to the deep hunger in this country, a hunger for equality, a hunger for justice, a hunger for inclusion, a need to approach this work with strong leadership, collaboration, integrity, and excellence. And as it turns out, those things I just mentioned are the core values of AMCHP. And I think that's why this work in this organization resonates so deeply with many of us. Those not only are the core values of our association, but also of so many of you, my colleagues who are doing this great work. So I hope that you too find gladness in your work. I hope you know how grateful I am for your enduring commitment to the deep hunger that exists among the children and families in this country. Thank you for that commitment. Thank you for your friendship. and thank you for the opportunity to serve alongside of you. Thank you. One thing we know, oh, am I supposed to keep going? Can we do this? You got that? Oh, you're doing that.
Okay, teamwork here. Okay. So we're just going to take a minute to honor the past presidents of AMCHP. If you're in the room, if you would stand. And now Michael joins this elite group. So we just take a minute to honor the past presidents. Thank you so much. You'll recognize a lot of names and leaders, so great. Now I'll turn it back over to Michael.
Great.
Okay.
So that really is an esteemed group, and I feel very privileged to be a part of that. Turn now to a couple of presentations before we get to our keynote. Now I get the opportunity to present the Ryan Colburn Scholarship, which is given each year to an individual for outstanding youth leadership in the field of maternal and child health. The scholarship specifically provides a youth leader with special healthcare needs the opportunity to attend the AMCHP annual conference, connect with youth and family leaders, all AMCHP members, and to participate in other leadership and learning activities for further professional growth beyond the annual conference. The award was established in 2010 in memory of Ryan Colburn, a youth leader active in MCH and special healthcare needs issues in his home state of Alabama and at the national level. The award is sponsored by donations and gifts, and we thank all of you who donated to the fund this past year or participated in one of the scholarship's fundraising events. The scholarship award truly embodies the spirit of Ryan and is a fitting tribute to his life as a leader and advocate for children and youth with special healthcare needs. I'm pleased to present this year's scholarship to Ms. Hope Hoffman of Champlin, Minnesota. Hope has an impressive history of accomplishments, including she developed a blog, Camo Girl, at age 15 for other young women living with disabilities. In 2016, she was appointed to the Young Women's Initiative of Minnesota, a public-private partnership between the Women's Foundation of Minnesota and the Office of Minnesota Governor Mark Dayton. The 7-year initiative has appointed young women leaders from 8 different community groups. Last year, Hope was elected among 25 fellow cabinet members of the Young Women's Initiative to serve as representative on the Young Women's Council with 70 other appointed elected officials, business owners, and philanthropists. This year, she was also elected by her fellow members to co-chair the Young Women's Initiative Council on Leadership and Respect. Most recently, she collaborated on a video with Rooted in Rights regarding the international symbol of access. Hope is a true youth advocate. Despite her young age, she has demonstrated skill and experience in public speaking, policy work, drafting legislation, providing testimony, and community engagement. Hope is a wonderful example of a young leader. Through her tremendous initiative and motivation, she has brought about positive change to the lives of young women and men with special healthcare needs. Her energy is contagious, and her motivation and drive inspire others to engage and act. Unfortunately, she could not join us this year due to an emergency, but we wish her well. She looks forward to coming to the 2019 conference in San Antonio to be recognized in person. So I will now present the Vince Hutchins Award. In 1998, AMCHP launched what was then called the AMCHP Leadership Award to recognize outstanding individuals whose work has contributed to significant societal changes that have resulted in improvements in the health of American families and their various members. Prior awardees have demonstrated accomplishments that advance, directly or indirectly, the health of American women, children, youth, and families, including those with special health care needs. The first honoree, former First Lady Hillary Rodham Clinton, is exemplary of the stature of Leadership Award recipients. In 2001, AMCHP renamed the Leadership Award for Dr. Vince Hutchins, a beloved national leader and lifelong advocate for children's health. During 15 years as director of the Maternal and Child Health Bureau, Dr. Hutchins expanded the federal government's commitment to women, children, youth, and families. He also led development of new initiatives for children and families, such as the Healthy Mothers, Healthy Babies Coalition. In honor of Vince Hutchins, this award continues to recognize leadership in promoting a society responsive to the needs of women, children, youth, and families. I'm so pleased to present this year's Vince Hutchins Leadership Award to Maria Nardella, recently retired and former Title V CYSHCN Director for Washington State. Congratulations. I have some nice things to say about her. I just told her I have some nice things to say about her, so we'll ask her to wait just a second. Maria is a lifelong advocate for women's and children's health, particularly for children and youth with special health care needs, making significant contributions to maternal and child health throughout her 41-year career. Keystones of her work include working to develop training and leadership projects related to the Title V transformation, supporting the development of the Nutrition Network for CYSHCN to build and expand workforce capacity for nutrition services for families and CYSHCN through community-based interdisciplinary feeding teams, leading efforts in payment and policy reform in partnership with Medicaid to support reimbursement for nutrition services, which also helps set the standard for private insurance reimbursement, spearheading the expansion of access to services for children and youth with special health care needs, specifically those with neurodevelopmental conditions, through innovative partnerships between Washington Title V and Medicaid to provide community-based therapies, leading the Medical Home Neighborhood Project within the Pediatric Transforming Clinical Practice Initiative, seeking to improve the quality of care and health outcomes for children on Medicaid through value-based payment and bidirectional integration of physical and behavioral health. Through her leadership, Washington's Title V program has provided funding to other family-led initiatives, including the Washington State Fathers Network and Washington State Parent to Parent. She's also a former AMCHP leader, having served on the board of directors from 2010 to 2013. Perhaps the greatest way to demonstrate Ms. Nardella's accomplishments is by quoting one of our former peers, Bonnie Strickland, the director of the Division of Services for Children with Special Health Care Needs at the Federal and Maternal and Child Health Bureau from 2006 to 2014. Bonnie said, "During my time with MCHB, we always look to Washington and Maria for new ideas, expertise, evidence of feasibility, and critical analysis. Under Maria's leadership, Washington has been a national bellwether for literally all national MCH policy for decades, producing ideas, models, and groundswell that ultimately spread and became or influenced national policy. Please join me in congratulating Maria on the Vince Hutchins Leadership Award."
Well, thank you very much for this award. I'm really honored. When I heard I was getting the Vince Award in February, I was hoping I was going to go home with a diamond-studded Super Bowl ring, but this will work. This is very good. So thank you very much. I wanted to share. Let's see. I can see it on my screen, but I wanted to acknowledge the people that really got me off on my trajectory in this career of children and youth with special health care needs. And I don't know if there's a pointer, but my first job out of college was in a sheltered workshop for adults with disabilities. And it was my first management job. I was the supervisor of a cafeteria as the nutritionist that served as a training ground for young adults and adults to become competent food service workers out in the community. So myself and the cook were the quote-unquote normal people at this organization called STAR in Darien, in Norwalk, Connecticut. And if you can tell where I am, I'm in with the cook's hat in the very back. We're really about 12 o'clock. Can you see which one I am? I have dark hair. I have a hat on. I was probably 23 in this picture, and I really had never been immersed in this world of people with disabilities, and I loved it. And it also, personally, the guy right in front of me, his name is Nick, and his parents were really closely involved in this workshop as well, and I really came to value working with parent leaders as well. And his mother, it turns out, I learned how much I had in common with Nick, and he and I both had grandparents who immigrated from Italy to the very same town in Darien, Connecticut, and our mothers grew up on the same street. And we even shared the same birth month and birth year. But Nikki was born with Down syndrome, and I wasn't. And that really hit me in terms of what responsibilities, do I have to go on a different trajectory that Nikki would never go on. So I was hooked. It was a population I loved working with. One day I discovered a job ad in a professional journal for a nutritionist to work in a facility to provide clinical care, training, and research in the field of children with special health care needs. And I suddenly realized what my dream job would be. But I knew I was not at all qualified for this. I went to probably one of the best nutrition programs in the country at Cornell, but they had one teeny tiny paragraph about working with people with disabilities, which was basically about PKU. And I knew I didn't have the background, and I felt so much need for this population. So I wrote to this job ad to tell them, I'm not qualified for this job, but how can I become qualified? And that's where they wrote back to me, and they told me about the network of university-affiliated programs that were out there, which was the precursor to LEN programs. So when it was time for me to finish that job and go on to graduate school, I ended up going to the University of Washington and that LEN program that had reached out to me. And I got the best training. My whole career really is a product of the whole Title V system. That interdisciplinary training I got as a nutrition consultant, working with OTs, PTs, doctors, nurses, the whole realm, and then always, always, always the family stayed with me for my entire career. And so I first became I've worked in 2 Title V programs in the country. First as a nutrition consultant in Arizona, providing direct nutrition services, family by family, child by child. And then I expanded to try to do more systems improvements for nutrition services first, and then as a Children with Special Health Care Needs Director of the entire Children with Special Health Care Needs program. So I really appreciate and acknowledge those of you in the room that have worked with me state by state, region by region to help make systems improvements. And I really feel like there's many other people that are as deserving of this award. I just am fortunate enough to have had coworkers who took the time to pull together the nomination for me. So I really want to acknowledge those people for doing that last fall. I truly, truly appreciate it. And I know a number of you probably helped contribute, my colleagues across the country, colleagues at MCHB, and at AMCHP. And I also want to put in a plug. I think one of the peaks of my career was being on the AMCHP board and really working with those dynamic, dedicated people. And if you ever have a chance to do that, go for it when you feel you're in a position to do that. So truly appreciate that. I've heard that in some cultures, when the people get to be the senior staff, they move on to make room for younger generations to actually create those job opportunities. So part of that, my time has come for that. Part of that, I think, is a lot of the MCH workforce is retirement ready right now, but a big piece of that is succession planning. So I feel like I've done that. I've set the stage for the Washington State program to continue in really good hands. And I feel confident that there's still plenty of work to do. And so not just in Washington State, but across the country, have to keep pushing for that MCH population improvements for systems to work. So really, thank you so much for this award. I truly, truly appreciate it.
So it is now my great pleasure to introduce our keynote speaker for our closing session. Dr. Michael Liu joined George Washington University in November 2017. As the Senior Associate Dean for Academic, Student, and Faculty Affairs, Dr. Liu provides leadership and vision for the school's educational mission and coordinates services and supports to help all students and faculty succeed. Prior to joining GW, he was the director of the Maternal and Child Health Bureau for the U.S. Department of Health and Human Services from 2012 to 2017. He led a federal bureau with an annual budget of more than $1.2 billion, serving more than 57 million women, children, and families nationwide. During his tenure, Dr. Liu transformed key federal programs in maternal and child health, launched major initiatives to reduce maternal, infant, and child mortality in the United States, and was awarded the prestigious Herbert H. Humphrey Award for Service to America. He joined the federal government from UCLA Schools of Medicine and Public Health, where he held a joint faculty appointment in obstetrics and gynecology and community health services for nearly 15 years. He was best known for his research on racial ethnic disparities in birth outcomes and his leadership in developing, testing, and translating a unified theory on the origins of maternal and child health disparities based on the life course perspective. In the past, Dr. Liu served on 2 Institute of Medicine committees, the CDC Select Panel on Preconception Care, and chaired the HHS Secretary's Advisory Committee on Infant Mortality. As an obstetrician, Dr. Liu has attended over 1,000 births and has been voted one of the best doctors in America since 2005. He received his master's degrees in health and medical sciences and public health from UC Berkeley and medical degree from UC San Francisco. Please join me in welcoming back Dr. Michael Liu.
Thank you. Good afternoon. So it's great to be back at AMCHP. It's great to see all of you again. Let me just start by thanking Lori. When Lori asked me a couple weeks ago to stand in for Dr. Fitzgerald, I said yes right away, not just because I can never say no to Lori. She really has been such a tremendous, such an amazing colleague and partner and friend, so thank you, Lori. But I also wanted this opportunity to come and say thank you to you in person. Thank you for all the support, all the guidance, all the partnership that so many of you have so generously gifted me over the past 6 years. I think together we've done some good. Together, we made a difference for kids and families around the country. But I know very well that I couldn't have done any of it without your help. So I really just want to take a moment before I get started to say thank you. You rock. Okay. Thank you for all your friendships. Thank you for all your partnership. And thank you for all that you do every day to improve health and change lives for children and families all across all across the country. So thank you. Now, many of you have been asking me, so what have I been doing, what I've been up to since I left AMCHP about 3 months ago? Well, as you can tell, I'm working on a new look. So I can look cooler to my teenager, and I'm still working on it. But I also got a new job at the School of Public Health at GW, George Washington University, where I'm the Senior Associate Dean for Academic, Student, and Faculty Affairs, which is basically a long title that means I work for everybody at the school. So half of my job is purely administrative, right? Providing oversight and leadership for the operation of a school with more than 200 faculty and more than 300 faculty and more than 2,000 students. But half of my job is actually incredibly creative because as the chief academic officer for the school, it's my responsibility to make sure that all GW graduates have the knowledge, the skills, the experiences to go out into the world to make the biggest difference that they can for public health, to become an effective agent of change, not only to solve today's problems or meet today's challenges, but to lead the future of public health. So that's got me thinking a lot about the future of public health. What will that future look like? And what will the next 10 to 20 years bring? And what do I have to do to prepare my students, to paraphrase Wayne Gretzky, to where public health is going to be and not where it has been? And that's also got me thinking a lot about the future of maternal and child health, which is still near and dear to my heart. What will our future look like? I really think that how we're going to do MCH in the next 10 years is going to be dramatically different from how we've done it over the last 100 years. Over the next 10 years, we are going to have unprecedented opportunities to really do something about improving maternal and child health, both in this country and around the world. But at the same time, we're also going to face some unprecedented threats to the population health of women, children, and families. So as MCH leaders, how do we prepare ourselves and the field for all those opportunities and all those threats? So that's what I want to talk about today. What will the future of maternal child health look like? What are those big opportunities and big threats over the next 10 years? And what do we have to do as MCH leaders to lead the future of MCH? So let's start with opportunities. And I think some of the biggest improvements in maternal child health over the next decade will come from scientific advancements. All you have to do is just think back to the last 10 or 15 years and see how far we've come as a field. Everything that we've been learning about the life course health sciences, about epigenetics and developmental origins of health and disease have completely transformed our field. It has changed our paradigm in MCH. We now understand so much better about how health and disease develop over the life course, which has completely redefined our work. Beyond just gap filling or wraparound for healthcare, and we're more than even just health promotion and disease prevention in MCH. We are in the business of building, producing, manufacturing, and optimizing population health for the future. So just like automakers make cars and pharma make drugs, MCH is in the business of making population health for the future. And over the next 10 years, we're going to learn so much more about just how to do that. How do we create those conditions that's going to turn on the genes that can make good health for life? And how do we turn off those genes that's going to cause cancer, diabetes, and heart disease 50, 60 years later on? And how do we create those conditions that's going to shift the curve on population health and bend the curve on healthcare costs and give every child and every family a fair shot at reaching their fullest potential? That's what I'm excited about. And I think it's going to be really exciting to work in MCH over the next decade. Another big opportunity for improving maternal child health over the next 10 years will come from all the technological innovations, which I think is going to transform the way we do our work in MCH. So let's take prenatal care as an example. I think right now, our prenatal care is still stuck in the 1980s. Today, for most American women, they still make roughly 10 to 15 visits to the doctor's office for prenatal care. And for many low-income women, that means taking unpaid time off from work, arranging childcare and transportation, changing several buses to get to the clinic, just to wait there for an hour or two for that 5 or 10-minute visit, which mostly consists of a urine dip and a blood pressure check, a fundal height measurement, which is incredibly unreliable, okay, and a cursory listening of the baby's heart rate through the dot tone, and a hurried conversation with the doctor who, despite the best intentions, just doesn't have the time to tell you everything you need to know about self-care, let alone dealing with all your psychosocial issues or occupational or environmental exposures, right? So is that the best we can do for moms and babies in this country? Is that really the best we can do in 2018? Probably not. Right? So how do we do better? How do we redesign prenatal care? How do we bring prenatal care into the 21st century? All right. So what if we can collect high-quality information on a more continuous basis with the use of wearables and sensors and lab on a chip from the comfort of the woman's own home? And what if we can collect information that, in addition to blood pressure and urine protein, We collect information that are just really important for pregnancy outcomes, as well as developmental origins of health and disease, right? Information on nutrition and physical activities, on stress and sleep, on occupational and environmental exposures, things that you just can't collect from a 10-minute visit. And what if all of this information can be transmitted into the cloud, okay? And then with the help of artificial intelligence, it gets transmitted back so that we're triaging women to who's doing just fine, who could probably use a call from the health educator, who needs to make an appointment to come in and see the doctor tomorrow, and who probably needs a home visit this evening. And what if we can bring design thinking to redesign prenatal care around the needs of the woman and family, and not just the convenience of the doctor or the efficiency of the system? So many places are beginning to experiment with virtual prenatal care that offer 24/7 access, okay, to the healthcare provider, which could really expand access, especially for those with limited access, people who can't take time off from work, people who can't arrange transportation, or people who live in under-resourced or remote areas. Redesigning prenatal care. And what if we could put technology to work for children with special healthcare needs and their families? What if we can transform disability into superability, and is that a desirable social goal? So this is Amy Mullins, who lost her legs as a young child, and Professor Hugh Herr at MIT, who lost his limbs during the climbing accident. And today, both of them can actually run faster and climb higher than most of us could. So I came across this story last year that deeply moved me. So Cam is a 4-year-old who was born with fused hand, who despite multiple surgeries and skin graft, so doesn't have good use of his hand. And that is until 2 6th graders from South Carolina, right? 6th graders from South Carolina, okay, with the help of a 3D printer and a design that they downloaded for free from open source files in this e-community called Enable, they made a hand for Cam. So today, Cam can actually ride a bike and hold a baseball bat, thanks to technology, innovation, crowdsourcing, and some big hearts. So over the next decade, there are more and more of these technological innovations on the horizon that are really going to change the lives of children with special health care needs and their families for the better. Contact lenses for non-invasive glucose monitoring for children and youth with type 1 diabetes, to save them from all the pains of having to prick themselves several times a day. Machine learning and AI that could really help a care coordinator better coordinate care and help families navigate the system and connect to services. Now, before we get all caught up in the glitz and glamour of technology, let me just say a couple words of caution. Number one, technology can never replace human touch. Okay? Technology can never replace human touch. We in MCH need human touch. But if we can use technology properly, high tech can actually enhance high touch. Two, technology doesn't automatically advance health equity. In fact, my friend Paul Wise wisely reminds us that technology can actually widen disparities if there's differential access. So a central challenge for us in the future will be, how do we put technology and innovations to work for health equity? Another opportunity that I see on the horizon for improving maternal child health is big data. Now, I know you've been hearing a lot about big data. It's basically just a fancy term for having a lot of information, often from unrelated sources that you can link. So in clinical medicine, they're linking genomic with other omic data with clinical and administrative data to help doctors better predict and prevent diseases and personalize treatment according to their genomic and other profiles. So not one size fits all, but the right drug for the right patient at the right time and the right dose. Okay. That's what precision medicine is all about. But how do we use big data in public health? Well, in addition to biological and clinical data, we can now bring in environmental data, economic data, social data, even geospatial and climate change data. Okay. A good example of this is the Juniper's Pollens Project, where researchers in this project is trying to improve prediction of the timing and pattern of the juniper pollens release so that they can give early warnings to kids and adults with severe asthma and allergy. Okay. So they pulled together 3 different sources of data. Satellite images from NASA, who's monitoring closely the exact timing of pollen release. Weather data from researchers at the University of Arizona who are using these analytic models that they develop for predicting dust storms. Now they're using it to predict pollen storms. And on-the-ground verification from local volunteers who are collecting the actual pollen sample. So when was the last time that NASA scientists, weather researchers, and local pollen chasers come together to work on improving MCH? Okay. It sounds like a bad joke, right? You know, NASA scientists and researchers and pollen chasers walk into a bar. Okay. But it's that kind of transdisciplinary collaboration aided by big data from perhaps unrelated sources that's increasingly going to be the wave of the future. That's how we're going to be doing our work in MCH in the future. So I think big data actually holds big promises for MCH. So in research, if we're able to link all sorts of data, okay, from cell to society, from neurons to neighborhood, from preconception to old age, that may actually help us better understand how health and disease develop over the life course, and what makes some people healthy, and what makes other people sick. And in practice, if we're able to link a whole bunch of data from all the wearables and sensors and all the clinical and social data, crowdsourced from millions of end users, that may help us develop better predictive analytics to help us identify which women are at greater risk for preterm birth and which kids are at greater risk for developmental delays, and that allowed us to intervene earlier. And much like in precision medicine, if we're able to link all of these data from multiple domains, it could actually help us identify the right intervention and tailor them to the risk profile of the families or community so that we're adjusting to the differential risk and vulnerabilities of the populations that we're serving. So the right intervention for the right population under the right circumstances, moving us toward precision public health, precision MCH. Now, before you get all caught up with the promises of big data, let me talk a little bit about the potential perils of big data. Big data can cause big errors from all the spurious associations and ecological fallacies, and that's why big data still need to be built on strong foundation of fundamentally sound MCH epidemiology. Big data can cause big problems with privacy that we really need to address. And again, just like technology, big data may widen disparities if there's differential access. And so, once again, a central challenge for us in the future will be how do we use big data, how do we put it to work for marginalized population for health equity. Now, despite all the things that I said about science and technology and data, I still believe that the biggest improvements in maternal child health over the next 10 years or 100 years will come from improving social conditions for women, children, and families. Let's not forget that some of the biggest gains in MCH in the last 100, 150 years came from promotion of hygiene and sanitation, child labor laws, women's suffrage, and overall improvements in educational attainment, economic opportunities, and social status of girls and women in our society. That's our history. That's been our legacy. But somehow, somewhere along the way, I think it was around the 1970s, where we lost our ways. Somehow we became a gap filler, a wraparound, a safety net, an afterthought for healthcare. So if we really want to move the needle in MCH in the next 10 years or in the next 100 years, we really have to get back to our legacy. We really have to work to fix social determinants, fight social injustices, and creating those social conditions in which all women, children, and families can be healthy and thriving. Now, let's talk about threats. What are some of the biggest threats to MCH over this next decade? I'm going to start with climate change. Okay? We certainly don't talk enough about climate change in MCH. Okay? But if the hurricanes in Texas and Florida and Puerto Rico and Virgin Islands and the wildfires in California is just a sign of things to come, we have to start talking. Climate change has already been identified by WHO as one of the biggest threats to public health in the 21st century. It could certainly have devastating impact on maternal child health, right? From weather-related disasters like hurricanes and wildfire, and the rise in sea levels, which could flood our coastal cities from New York to California, from Palau to Micronesia, to the spread of vector-borne infectious diseases like Zika. And you see on this map, we got these tropical vectors that are spreading as north as Maine and Washington because of climate change. To severe droughts that could have devastating impact on food production as well as air quality, all of these can have significant effect on maternal and child health. So as MCH leaders, we can't just sit on the sideline and do nothing. We can't sit this one out. So what can MCH do? First, MCH researchers and funders must prioritize climate change research in the next decade. Second, MCH advocates need to join forces with other climate advocates to promote practices and policies that will promote clean and renewable energy, reduce carbon emission, support smart refrigeration, and all the policies to reduce global warming. And third, and very importantly, every state Title V program needs to work with the state FEMA to put a statewide comprehensive emergency preparedness plan and system in place for MCH, especially a plan and system in place for pregnant women, infants, and children with special healthcare needs so that we're not scrambling the next time a major disaster strikes. Another major threat to MCH is going to be infectious outbreaks. And just 2 decades into the century, we've already seen bird flu, SARS, MERS, Ebola, Zika, chikungunya, dengue, and who knows what pandemics still lurking out there. And all of this is driven by climate change, urbanization, globalization, and so this is just going to get worse over this next decade. And what makes matters even worse is this growing antimicrobial resistance and the emergence of these superbugs that's making treatable infections increasingly untreatable. The CDC estimates that each year in the United States, about 2 million people are infected with a bacteria that's resistant to antibiotics, and about 22,000 people die from it every year. And a recent study in 48 children's hospitals found that the rate of multi-drug resistant E. coli infections actually increased by 8-fold from 2007 to 2015, and that should worry all of us. And this problem is preventable. Much of what's driving this problem is inappropriate antibiotic prescription. It's been estimated that roughly half of all antibiotic prescription in the US are totally unnecessary. This problem is also driven by inappropriate administration of antibiotics to livestock, which account for about 80% of antibiotic use in the United States. I think MCH can actually play a very big role in terms of supporting coordination between public health and clinical pediatrics to implement in every state and every community responsible antimicrobial stewardship in MCH. Globally, we also need to establish a global early warning system using the combination of both microbial whole genome sequencing as well as social media, social network analysis, so that for early detection, early warning of infectious outbreaks and antimicrobial resistance. And one more thing that we can do is we can all learn more about One Health, something that I really didn't know much about, which is the idea that the health of people is very much interconnected with the health of animals and the health of our planet. If you want to learn more about One Health movement, I put the link for the CDC website on the slide. Another major threat to maternal child health is this growing burden of chronic diseases. We know that about 38% of American children have a chronic health condition based on the latest National Survey of Children's Health from 2016. Roughly 1 in 5 American children now have a special health care need, and roughly 6 to 8% of American children have a severe disability that limit their activities of daily living. About 1/3 of American children now are overweight or obese, a rate that has more than doubled in the last 25 years. And we're getting increasing reports of anxiety and depression among our children and adolescents, with about 30% of high school students who reported depressive symptoms over the last 12 months. But all of our problems pale in comparison to the growing burden of chronic diseases in adults, with 80% of adults 65 and older having at least one chronic condition, and 2/3 having 2 or more chronic conditions. More than 1 in 4 have diabetes, more than 1 in 10 have Alzheimer's disease and other dementia. And there are 50 million adults 65 and older, which is projected to grow to 70 million in the next decade. And I think all of these chronic diseases are going to put increasing strain on both the health system as well as our national political will to make the kind of investments in children and families, to make the kind of investments for the future of our nation. Again, what can we do about this? First is to intervene early. Right? Everything that we've been learning about developmental origins of health and disease is that we're probably doing too little too late. And that if we really want to prevent child obesity, or if we want to prevent chronic adult metabolic syndrome, we really have to intervene maybe before the baby's even born, or better yet, before conception. Second is we need to pay attention to the social context, the social determinants of these chronic conditions. So food desert for obesity, substandard housing for asthma, and ACEs and neighborhood violence for some kids, and social media and overachievement pressures for other kids that may be fueling this rise in anxiety, depression in adolescents in our country. And third, we need to support a lot more research. What is going on? What is really driving this rise in chronic conditions, and what can we do about it? And we need not only clinical, but population-based interventions, prevention, and intervention strategies that work. And let me just say a word about one more thread, and that's really our decaying infrastructure, starting with our nation's drinking water system, okay, which just got a grade of D from the American Society of Civil Engineers in 2017. And if you don't think this has anything to do with MCH, just remember Flint. Right? All the time last year that I was trying to figure out how do we stretch the money that we got from Congress to make sure that each and every one of those 16,000 kids who were exposed to lead-contaminated water get all the services and supports that they need to minimize developmental delays. Deep down in my heart, I knew that there are so many more neurotoxicants than lead, and there are many more affected communities than just Flint that we're not paying attention to, including these 1,300 Superfund sites that still need to be cleaned up, that millions of children and families are exposed to every single day. So I'm glad there's now some talks about infrastructure. If that's something that we could do for children and families over the next 3 years, let's make sure that we turn talks into real action that actually fix our nation's drinking water system and hazardous waste management system. And in addition to building roads and highways and fixing bridges, let's make sure that we're building more sidewalks and bike paths and public parks and public transit. And let's also learn how to activate citizen science in environmental monitoring to monitor air pollution and water pollution. By mobilizing a whole army of ordinary citizens and giving them some simple test kits and a little bit of training, we don't have to wait for EPA to do something, right? We can actually crowdsource environmental protection for our children's future. Right. So in light of all of these opportunities and threats, what can we do as MCH leaders to lead the future of MCH? Let me just leave you with 5 things. First, let's start talking. Yeah. This popular movie from the late 1980s, starring Ken Harris and Eileen Forlenza, which actually got 2 thumbs up from Cisco and Ebert. Okay. We got to start talking. Right? The reason I want to come and do this talk today is not because I have all the answers or a crystal ball. The reason I want to do this talk today is to start a national conversation, to start some collective visioning about the future of MCH. As MCH leaders, that's our leadership responsibility to lead our field into the future that we want. It's a future that's driven by our core values rather than by political or market forces. A future that's driven by science and evidence and not politics or ideology. A future where technology and innovation bring people together rather than drive them apart. That they close the disparities rather than widen the gaps. And the future that, most importantly, puts kids first and families front and center in everything that we do. So that's the future I want. What's the future that you want? I don't know if we have time for a town hall today, but I would certainly hope that maybe we could use some time next year to really have a conversation about the future that we want. In the meantime, you can go ahead and send me an email. Tell me what's the future that you want for MCH, and how do we get from here to there? Second, as Apple CEO and one of the most amazing MCH epidemiologists, Bill Sappenfield, reminds us, we got to keep on innovating. I know that's really hard to do, to talk about innovations in an environment where we're just trying to hold on, trying not to lose any grounds. But it's exactly times like these that we need to bring our best creativity, our best innovations. I think it's also exactly times like these that we need to come together. See, one thing I've really learned over the last 6 years about MCH is that we innovate much better together. And that's because we come from different backgrounds and different disciplines. We bring different experiences and different perspectives, different talents and different strengths. And e pluribus unum, out of many, one. As a field, we are at our best when we come together to solve a problem. I saw that with all the coins. I saw that with all the research networks, recognizing that diversity and transdisciplinarity, two of our biggest strengths, are also going to be some of the biggest drivers for innovation in the 21st century. But let's not just stay within MCH. I truly believe that new ideas, new discoveries, new breakthroughs, new solutions in the 21st century really shouldn't be bound by institutional, disciplinary, or national boundaries. That we can crowdsource innovations, which is really what we try to do with the Work App Challenge. And we actually got really innovative ideas from Silicon Valley tech startups, as well as farmers in Iowa. And that's what we're going to be hoping to get in the next round of MCH Grand Challenges that the Bureau's getting ready to launch. Crowdsourcing innovation to innovate the future of maternal and child health. Third, as the famous ring announcer and the 2018 McQueen Award winner, Dr. Antonelli exhorts to us, let's get our workforce ready for the future. Let's get them ready for where MCH is going to be and not where MCH has been. And that's what I'm trying to do at GW, making sure that all of my students, all of our GW graduates have the tools, the skills, and the experiences to go out and make a difference for tomorrow. That's what all the MCH leadership training program, all the Catalyst programs, all the training programs are trying to do, preparing our next generation of leaders to lead the future of MCH. I think that's what the MCH Workforce Development Center and the MCH Navigators were designed to do, giving Title V and MCH Workforce 21st century tools to solve 21st century problems. But there's still more that we can do. Let's make sure that we're teaching to the future and not just to the past. Make sure that we're teaching, getting our workforce ready for all the opportunities and all the threats that I just talked about. And let's make sure that we're teaching skills and not just content. If you think about a lot of what I talked about, a lot of the future roles of MCH is going to be in designing new systems. So let's make sure that our workforce is trained in system thinking and design thinking. And a lot of what they're going to be doing in the future is about leading change. And let's make sure that they know about change leadership, improvement, innovation, collaboration, policy, and advocacy. And a lot of what they have to do in the future is to adapt to an ever-changing environment. So let's make sure that they have those critical thinking skills and lifelong learning skills to really help them adapt and thrive. And one more thing, let's make science and technology work for us in MCH education and training. Someday, I would really love to see an open source MCH university where no matter where you work in MCH, whether you work at the local health department in Jackson, Alabama, or you work in the family planning clinic in Nicaragua, that you should have access to the best tools and MOOCs, the best courses and resources for free online. That's going to help you make the biggest difference for the children and families that you serve. Number 4, as this movie from starring Laurie Freeman and Michael Warren kind of reminds us, we need to get back to the future, remembering what I said, that some of the biggest gains in MCH over the next 10 or 100 years will come from improving social conditions and fighting social injustices. Okay. The biggest gains in MCH over the next 10 to 100 years will come from improving social conditions and fighting social injustices. Yes, that means working across sectors and across silos: health, education, economic development, community development. But it's going to take a lot more than just bringing people together to collaborate, to sing Kumbaya, right? What it will take is a clear purpose, a common agenda, shared measurement, coordinated strategies, and continuous communication, as well as a backbone organization to achieve the greatest collective impact. But let's not just stay downstream. Let's go upstream to fight all the policies that are pushing kids and families into deep water today. Policies such as some of the proposed Medicaid waivers and executive orders that are going to set MCH back by more than 20 years. Policies such as some of the budget cuts, which I think just totally immoral, okay, that are going to harm a lot of kids and families all across the country, including children with special health care needs. And policies that have to do with deregulation of environmental protection that are going to be robbing from our children's future. And I'm tired of just fighting the good fight, right? Let's fight to win. Okay? Let's fight smart. Let's fight to win. Okay? This means that over the next 10 years, we need to infiltrate. Okay? Infiltrate every decision-making body that are making policies that have major impact on maternal and child health. Okay? From the White House to every state house. Okay? From the halls of Congress to every city hall. From corporate boardrooms to every federal courtroom. And let's put MCH in positions of power over the next 10 years. Okay? And we don't want just a seat at the table anymore. We actually want to sit at the head of the table, right? Remembering very well that Martha May Elliott did not just stop at preventing rickets or running the bureau. She actually drafted most of the language for Title V of the Social Security Act, which has shaped the future of maternal child health for the next 100 years. And what we need is a whole generation of new leaders like Martha May Elliott to stand up, okay, to fight and to win and to lead the future of maternal child health by getting back to the future. And let me just leave you with this one last message, this one final message. As the lead singer and the Bureau's acting director right now, Laura Kavanaugh, reminds us, don't stop believing. Okay, don't stop believing. Now, I know that's hard for some of you to do. Okay. To some of you, it may seem like we're going in the wrong direction. That somehow this is some of the biggest retrenchment in maternal child health in the last several decades. But again, it's times like these that it's so important for us to keep on believing. And this is where I'm reminded of a story that I was told by my friend and mentor, Magda Peck. Many of you remember Magda Peck. She's the founder and former CEO of CityMatch. So a few years ago, Magda did this amazing project during her sabbatical where she went around the country and interviewed some of the greatest heroes of public health in the 20th century. People like Julius Richmond, who founded Head Start. People like Bill Fahey, who eradicated smallpox from the face of the earth. And after she did all these 20 dirty interviews, she said that she found one thing that was shared in common by all of these great heroes of public health in the 20th century. One characteristic that characterized all of our superheroes in public health from 20th century. It's what she called an unwarranted optimism. Unwarranted optimism. They stay optimistic in good times and in bad. Here I'm also reminded of a parable that I grew up with as a child growing up in Taiwan about an old man who just one day decided, with the help of his family, his kids, decided to start moving the mountain that obstructs the way between his home and his field. And when mocked by a wise man about the futility of his effort, the old man simply replied that I myself may not succeed in moving the mountain, but my children and my grandchildren will continue to work, and one day the mountain will be moved. So let's keep digging. Let's move mountains. And if there's one take-home message from my talk today, and once you get home, if you could just do this one thing for me, okay? Make me this one promise. Keep on believing. Okay? Keep on believing because we can't help it. That's what we do. That's who we are in MCH. Keep on believing because we have to. Your staff, all the kids and families out there are counting on our leadership. And let me give you one more reason to keep on believing. I do have to apologize to those of you who have heard my personal stories like 10 times. But it's a story that has kept me believing all these years. Okay? So many of you know that I was born to 2 immigrant parents who never went to college. In fact, my mom, she never went to high school or even junior high. See, my mom was only 11 when her father died, so as the oldest girl in the family, she had to drop out of 5th grade to go work in the factory to help support the family. But when she and my dad first got married, they were still pretty poor. I was actually born to a home, this tiny little apartment on the other side of tracks in Taipei where a family of 6 was crammed into. No flush toilet, no running water. Health insurance? We didn't have health insurance because there weren't such things as health insurance. And so when you get sick, and unfortunately I was sick a lot as a child, you never knew how much the doctor or the medicine was going to cost. And my parents often had to make these difficult decisions about paying for food versus paying for medicine. And at one point, my mom actually sold her wedding ring to pay for my medicine. So I didn't come from an educated family or a wealthy family. But none of that mattered anymore once we came to this country. It didn't matter anymore because in a great America, you don't have to be rich to go to the best schools. And it didn't matter anymore because in a great America, everyone gets a fair shot, no matter where you're from, or the family you were born into, or the color of your skin. And it didn't matter anymore because in a great America, I knew if I just work hard enough and try hard enough, I can give my girls a better chance in life, the kind of chance that my mom would never even dare dream of. And that my two daughters, the grandchildren, the granddaughters of a girl who had to drop out of 5th grade to go work in a factory, can now grow up in a nation where they get to be anything they want to be. That's truly what makes America great. But if my girls can get that chance, why shouldn't every child in America get the same chance? If my girls can get a fair shot, why shouldn't every child get a fair shot? That is the future we're fighting for. That is the future that we all want. Now, you and I, might never get there ourselves, but let's keep on digging, and let's keep on believing, and one day our children and their children will get there, and that's what our work in MCH is all about. Thank you very much. All right, looks like we got 8 minutes and 12 seconds for a mini town hall here. So yeah, I'm happy to answer any questions that you have, but like I said, I don't have a crystal ball, I don't have all the answers. I'd rather hear from you in terms of your vision for what the future of MCH that you want, and how do we get from here to there. And I think we got open mics on both sides.
First of all, thank you, Dr. Liu, for this very inspirational talk. I really appreciate it because I just needed that reinforcement about how we can use technology, how MCH workforce can do truly transdisciplinary work. My question for you was, you posed all these challenges, and we've set a very ambitious goal for the next decade. I think there are some fundamental issues with respect to the institutional barriers. I mean, I was from University of Arizona, and we did some of really transdisciplinary work. I think one of the challenges is in trying to define this meta-discipline of MCH, what is your vision in terms of what the kind of curricula, what kind of skill set that the future, MCH workforce, I know you talked about it, but in terms of this boundaries about, I'm trained in this particular field, and this is my causal thinking, I'm only going to use DAGs, I'm going to only do this. How do we really transfer and kind of blend these strengths in different disciplines to come at this true meta-discipline to really handle the challenges that you've posed? Any comment would be really appreciated.
Yeah, no, thank you for that question. I do think that, and I want to pose that same question to all of you. I do think that this is the vital question for us in MCH for us to figure out what does that future MCH work look like? What are we going to be doing 10 years from now, 20 years from now? And what are the kinds of tools, the skills, the experiences that we need to have in order to be effective in doing that work? I threw out some ideas earlier. Like I said, a lot of what I just talked about, we're not the safety net provider. We're not just the wraparound, the care coordinator. But we are designing new systems that work. Right? We're putting systems in place, whether that's a system around antimicrobial stewardship or a system to make sure that we are prepared for the next disaster. Let's make sure that we have those skills to, for design thinking, for systems thinking, which I know that a lot of schools of public health still not teaching, but those are such important skills for us to have. And one thing I do know is how important it is to have those skill sets around leading change. Right? Something that I had to learn on the fly because I was never taught in medical school or residency about how to lead change. And yet these are going to become increasingly important skills as the world changes around us. Let's make sure that our next generation of leaders have the skills to really lead change, not just at the clinical level, but really at the population health level. So I'll throw those couple ideas out, but if others of you have ideas or comments, I would very much like to hear that either here or just send me a quick email. Thank you for that question. Yeah.
Sorry, I can sound off. I don't need a mic. Can everybody hear me? So what I wanted to say in response to your question, sir, one of the things that we had talked about, I'm currently a graduate student at George Mason University, and I'm also an Army nurse. And one of the things we talked about in the Army is we were trained, when I got my BSN, we were trained in vacuums, and we're still training in vacuums. Nurses and doctors are being trained as doctors, and social workers are being trained as social workers, and so forth and so on. One of the things one of our esteemed generals brought to our attention was we need to change that paradigm, and I hope that schools are going towards that, and I can see it firsthand at George Mason University, because we have what we call the MAP clinic, which is Mason and Partners. We actually have free clinics for the public. They actually have 8 free clinics in Fairfax County and Prince Williams County, Virginia, where we are training nurses alongside social work, alongside OT, alongside PT. They come to these clinics with the public, and they're training together. And that's something one of the generals in our Army stated was, we need to get to a place where we are a multidisciplinary team taking care of the public, and we don't need to be in vacuums anymore, because I don't know what the other disciplines do. They don't know what I do, and there's this expectation that, oh, well, the nurse, they do that, or the doctor, he does this, or the social worker, what have you. So if we can get everybody to train together, then hopefully we'll be working together better to solve a lot of these problems. Thank you.
Thank you. No, that really is a great point kind of around interprofessional training, around building teamwork, and around how do we collaborate effectively. And I do think that the expectation that collaboration will somehow occur spontaneously is the reason why most collaboration fails, right? And you've seen it over the last decade, right? Despite the best intentions, sometimes when people come together, things don't happen, and why is that? Okay? And so there's a lot more that we need to learn about the science of collaboration, and how do we bring those tools for effective collaborations to make sure that our future leaders have the ability to really promote that kind of teamwork and that type of interprofessional collaboration. I think we have time for one more. Okay, and I think we're running out of the last minute. So again, thank you all Just thank you for everything that you've done, all the good times that we had, all the tremendous partnerships that we had. I just want you to know I'm still here. I'm still here in DC. I may have other roles, but my heart's still within MCH. So thank you, and look forward to working with you all.
Thank you so much, Michael. I really have to thank you from the bottom of my heart. We really were in a tight spot. I asked you at the very last minute. I texted you. I got an immediate response. I was somewhere in San Francisco on a train. I had zero hope of you ever saying yes, and I'm torn between really missing you in your role at MCHB and loving you in your new role. And I love your new look, by the way, too. And I think we really want to pursue the conversation with you as much as we can. So looking forward to that. Well, it is that magical moment when we say so long until next year. And we hope you've really enjoyed your experiences this week in Arlington. And because quality is so important to everything that we do, please take the time to help us with our own QI processes and complete the meeting evaluation for this meeting. Your inputs really matter. I read every single one. All your comments are really important, and I take them to heart to improve the experience that you'll have next year. Finally, I hope you allow me one small recognition. Although Dr. Warren opened our meeting by publicly thanking the AMCHP staff, I'd really like to take the opportunity to thank them myself. They are an amazing group. They may not even be in the room. They're always doing something else. But would you please stand and allow us to all thank you for your hard work. They are what we affectionately call our AMCHPers, and a big kudos from me to them for all that they do, and not just for this conference, but every day at AMCHP. With that, I officially close the 2018 AMCHP conference. Thank you, and once again, really I look forward to you joining us in San Antonio next year in March. It's going to be a lovely place and lovely weather, and we're going to have a great time, just like we did this week. So I'll look forward to seeing you then.